All right. Well, welcome back, everybody, to the Pearls Train the Trainer course. This is webinar 2. Today, we're going to be talking about depression as it pertains specifically to older adults, the screening process and eligibility for enrolling new clients, and how to introduce Pearls to a participant. I haven't met all of you yet. My name is Caitlin Matt. I use she, her pronouns. I work with Kellyanne and Michelle and Leslie and Tony on the Pearls team here at the University of Washington Health Promotion Research Center. I've been with Pearls since about 2017, and I'm really happy to be here with you. Does everybody else, you all did introductions last week? Sort of know each other? Okay, great. Let me know if, oh, no, there we go. My first joining. Okay, great. Okay, here we go. So the learning objectives today, obviously, you all know this information, but we're going to be going through how to train others to recognize the things going on in older adults' lives that may indicate that they are having depression. Like they may have specific psychosocial needs or stressors that are either causing or magnifying their depression symptoms. So we'll be teaching you how to teach others to identify depression using scientifically validated instruments, and how to go about assessing people with clinically significant depressive symptoms to then make recommendations to improve their mental health and thereby their quality of life. So we'll go through the screening for Pearls eligibility and the process for enrolling a new participant if Pearls is a good fit for them. And then if everything works out and they're a good fit, how to then introduce the program and explain Pearls to a new participant. So a little bit about adult learning for today's lesson is really looking at these different orders of thinking skills. So, you know, we go through our life doing a lot of the lower level ones, just rote memorization and, you know, comprehending what we're doing. But when we're doing the Pearls training, whether it's in person or even doing the practice sessions online, we're really trying to push them up into some of those higher orders where they are taking the basics that they've learned either over the course of your in-person training or what they picked up on the modules in the on the online training, and really start to apply them, apply the skills, practice them, and start to think critically about what they're doing so that they can do the program well, but also then think about it critically in order to adapt it to be more effective and resonate better with the members of their communities that they're serving. So, you know, it's not just reading all of the stuff about what Pearls is and watching the videos, it's really applying those. So the teach back for today at the end of the class, take 2 volunteers, or I'll call on 2 people to be voluntold. And so I'm going to have you teach back sharing tips for administering the PHQ-9, because as part of the training, you may be teaching people all about the PHQ-9, what it is and how to administer it, but then some additional tips for being more successful as Pearls coaches in administering it. And then the second one will be about describing the 3 Pearls principles to a new participant. So as we go through the slides, just think about you get called on, or if you volunteer, like how would you teach this to others? So the first section today, we're going to talk all about depression. so the criteria for it, and we don't have any specific training, in-person training handouts that you would use, but you can always refer back to the toolkit section, recruitment and screening. That's a very helpful section. And then this correlates to the first module of the online coach training, where we just give a quick overview of pearls and depression. So dive in. So we're going to talk about how we talk about depression in specifically an in-person pearls coach training, how you're identifying, how they should be identifying depression, and then going forward with how to treat the depression. So just a reminder for you to remind them, we're not making a diagnosis, but we are assessing for clinically significant depressive symptoms that are interfering with the older adults' healthy living experience and happy lives. All right, so when we start talking about depression, so this is specifically for an in-person coach training, we like to do like a class sharing or brainstorming section. And if you have a whiteboard or a poster board, the Post-it note, the giant Post-it notes, basically, we often do just a brainstorm session. What are some of the causes of depression? Like things that come up, a lot of times you'll have case managers. What are things that they hear all the time? What are some of the symptoms that they're experiencing? What do they hear from the people that they are serving? And then on the other end, like what do those symptoms or causes, what are the outcomes of those? Like what are the results of that? And so helping them see sort of the life cycle of how the symptoms may be causing problems, or maybe there are specific problems causing the symptoms. And then it's leading to, they're having trouble adhering to medications or an exercise routine that they've been prescribed, or just their overall experience of life, their quality of life has gone down. So helping paint that picture for the coaches. And then really highlighting the overlap between those two lists. Like things can go in both directions, and it sort of creates like a Venn diagram almost, or like an infinity circle of this downward spiral where they are not feeling well, they are not doing very much, or they're not doing much, and that's making them feel worse, and it's this catch-22. So really diagramming that can be really helpful. There's a lot of different ways you can do this. This is one that we have done for a long time, and it's very effective. It gets people talking, chiming in and commenting on things that they all have already experienced in the field, even if they aren't or don't have experience specifically assessing or treating depression yet. So this is the sort of the foundation for examples that you will be using throughout the in-person training. When you're going through building a problem list, or when you are demonstrating how to complete a worksheet, you can really lean on this brainstorm that you've already created. Because there may be some, we always think of, there's a lot of really common examples of, chronic pain or, family conflict or whatever, but sometimes they give some really good examples from their caseloads that they've encountered, and they make really great examples later on in the training. So writing all those down is really helpful. Okay, so once they have sort of this picture in place, really taking a look at the differences between normal sadness and grief and depression. So what we want to do in the training is help them distinguish depression from other things that look like depression. And so we recommend that you start by defining each of these. So normal sadness is something that everybody experiences at some point. Sometimes it lasts hours or days, but it generally resolves without treatment. Grief it can be much more intense, and it's very severe sadness. It may last many months, but it does usually improve over time. And, you know, if it's not resolving, there are other treatments that folks may do, like counseling, for example, for more complicated bereavements. But the big differences are that these are things that generally do resolve without treatment, or they can resolve on their own without treatment. When we're looking at major depression or minor depression and persistent depressive disorder, it's more than just that feeling of sadness. You know, it's a syndrome of multiple symptoms, and it's lasting for at least 2 weeks, most of the day, nearly every day. And it usually does require treatment to move beyond. I don't keep up on all of the things psychological, but I did just realize yesterday that minor depression isn't necessarily recognized anymore as its own thing. So I left it in here though, because as you know, it takes like 10 years for changes in the DSM to really make it into practice. So minor depression is something that you may still, you know, if you're teaching others, they may still be looking for a difference between minor and major depression, or their funder might. So I'm leaving it in there. You can do with it as you please, depending on the audience that you're teaching. Persistent depressive disorder used to be called dysthymia, and it is multiple symptoms that overlap with major and minor depression. Most of the day, more days than not over the last 2 years. So think of it as kind of like low-grade depression lasting a really long time. And, you know, they may have breaks within that 2-year period where they're not experiencing it, but if any of those breaks last more than 2 months, then it's not considered persistent depressive disorder. Okay, so I will go through the differences between major and minor depression just so that you have it, and if it comes up, if that nuance comes up during your training, you have it, and if not, you can ignore me. But okay, so listed here are the 9 different symptoms that count as diagnostic criteria for depression. These are in order, basically the 9 questions on the PHQ-9. So those first 2, depressed mood and anhedonia, which is the loss of interest in things, those are the first 2 questions on the PHQ-9. And those are the cardinal symptoms. You need to have at least one of those 2 symptoms to be considered a depression diagnosis. So, you know, you have to have a score of a 2 or a 3 in one of those 2, and then you know, a certain amount of the other symptoms. So for major depression, you need to have at least 5 symptoms, at least one of which needs to be 1 or 2, the depressed mood or anhedonia. And this needs to be lasting at least 2 weeks. Minor depression, same symptoms, but you need to have at least 2 to 4 of those symptoms, at least one of which needs to be depressed mood or anhedonia, a score of a 2 or a 3. And when we get over to the PHQ-9, you'll see, like, the way we have it formatted is that the 2 or 3 scores are shaded a little bit darker gray, and it's helpful for you to highlight that for the folks that you are training, that it's not just graded for fun. Like, those are there to help indicate a more severe experience of that symptom. So to just make it easier for them to quickly identify whether it's major or minor depression. So we'll get into the screening tools a little bit more as we go through, but PEARLS uses the PHQ-9 for both screening and outcome measurement. Tends to fit better with the work that social workers or case managers are already doing. It's validated for older adults, either to be administered by you or by the coaches in person or over the phone or by themselves. So we'll talk more about that in a little bit. But you may get some pushback from folks who maybe they're coming from an organization where they use a different measure or a different tool, screening instrument. So a lot of times for brief screenings, especially in like a primary care setting, they may just use the PHQ-2, which are just those first two questions on the PHQ-9, because if they don't have one of those, it's not going to count as depression. Another popular one is the geriatric depression scale, and they do have a 5, 15, or 30 item. But the original research was done with the PHQ-9. That's what we've been using all along. But if you get pushback or questions, it is okay as long as the measures are brief and validated to be used with the population that they're working with. Okay, so pros are, it is validated for older adults. And the PHQ-9 doesn't require clinical, like a lot of clinical training or skill to be used. So, you may just be teaching case managers or social workers to do PEARLS, but you may not. You may have folks coming from all sorts of backgrounds, and they may not have ever seen a PHQ-9, and that's okay. They don't need to have seen a PHQ-9 to be able to learn how to use it as a tool effectively. Downside of the PHQ-9 is that it doesn't really necessarily capture some of the criteria outside of that DSM world. And we have some there are many translations of the PHQ-9 into different languages, but that may still not capture some of the cultural idioms of distress that they are experiencing. There's a lot of stigma among all populations. So you may need to help the coaches understand that they can use words that apply. They can ask questions in a different order. There's flexibility with the PHQ-9, and that's okay. All right, depression self-report. So it is a self-report tool. We are asking the client to give us a response about how they're feeling about certain symptoms. It can be a little bit problematic at times, and so it's important for you to highlight this for folks who are being trained, especially if they don't have experience with the PHQ-9. So they should trust their instincts as coaches, and if they feel like the participant is not answering truthfully for one reason or another, to feel free to probe a little bit more, or to take it back to you if you're their program manager, or to their program manager, or to more importantly, to their clinical supervisor. Sometimes clients may feel that there's a secondary incentive, either to under or over report symptoms, especially if they feel that their services may be threatened, or that's a big one, is if they're worried that answering one way or the other is going to affect something about their services. Remind the coaches that they need to remind the client that this is not affecting other services that they receive, either from them or from other sources. And sometimes coaches may pick up on feelings like the client is minimizing or denying their symptoms. Now, it could be between screening and one of the early sessions, there's some apprehension, or the rapport hasn't been built yet. It could also be that they're trying to please the coach and they don't want to hurt their feelings, especially if it is later on, and they don't want to hurt their feelings. And so reminding the coaches that to be, just matter of fact, neutral as they're administering the PHQ-9. And, I see this on practice sessions for the online coaches getting trained all the time is, you go through the PHQ-9 questions, and whatever they answer, they feel like they want to comment about whatever the answer is, good or bad. And so I always encourage folks to stay neutral, because you don't want them to start changing their answers to elicit a response from you as the coach. But also just like they need to get in the habit of getting through the PHQ-9. It's just taking the temperature of how the client is doing that day. They can know their score. It's not private information, of course, and it's not a grade. It's just taking the temperature and over the course of the program, seeing what changes. I also like to remind coaches that, it's not uncommon for there to be like a major dip after the program has started. Sometimes that's because the client is answering more honestly. Maybe something has shifted, or maybe the overall score has not changed much at all. And that's okay. That's where at session 3 or 4, if they're not seeing improvement, that's when you encourage them to talk to their clinical supervisor. That is what they are there for, to talk through, take a look at the medications at that point, things like that. But also remind the coach that the overall score may not be changing, but their experience of the symptoms might be. Like, even if it's not, moving from a 3 to a 0, that's okay. If they are reporting to you that despite the scores, they are feeling better in some way, or one of those symptoms is relieved, it's okay to highlight that so that, both the coach is not getting fixated on the score and the client is not. Oh, yes, and definitely working with the coaches that you're training, remind them not to go down that slippery slope of answering for the question or answering for the client. If they're wishy-washy on one of the symptoms, you can give them the example of like, well, would you say it's a 2 or a 3? But not leading them with, okay, so you're having some of that. Would you say that's a 2? That clients, especially experiencing depression, it's very easy for them to default into just like, yeah, sure, and not doing the mental work of thinking through what it is they are actually experiencing. So depending on your audience, you may need to spend more or less time going over the stuff on the PHQ-9. When Kellyanne and I were in LA doing an in-person training this spring, we had a huge portion of folks who were case managers or coming from organizations where they were very familiar with the PHQ-9. So we didn't have to spend as much time as sometimes I have in the past. And, that's A-okay. Just want to, you're going to have to read the room and try and identify if there are folks who feel that you're getting the sense that they need a little bit more help with the PHQ-9. You may spend a little bit more time with them in some of the practice breakouts on that, or encourage them to work on practicing with others at their organization or with a clinical supervisor after the training. They don't have to be perfect at it as the training's done. All right, so another thing to cover during this section is just how prevalent or common depression is. So certainly there's much more awareness out there now than when we first started training at Pearls. And especially since the last couple of years with the pandemic, the information is out there in a much more visible and accessible way, but there's still a lot of unknowns and a lot of stereotypes and stigmas around that. So, you know, the last line on this chart is particularly telling. So if you add up both the major depression and minor depression prevalences, you can see that about 2/3 of the people receiving home and community-based services, this was from one study here in Washington, 2/3 of those people were experiencing depression. And I can guarantee you that not all of those 2/3 of people were receiving proper care for their depression. They weren't able to access that. So it's out there. We have lots of resources that you can access to help convey that information to the coaches that you're teaching. But I promise you, almost everybody coming to the training in one way or another, they know that this is a huge need. So you don't have to convince them most of the time. More teaching them how to share the education with the clients that they're serving. Okay, so the last thing that we touch on during the in-person trainings is about common treatments for depression, because we know that PEARLS doesn't work for everybody, and that's okay. So don't take it or remind them not to take it personally if, you know, it's not working. Work with the clinical supervisor, do their best, but it's not going to be the end all be all for everybody. So these are some of the other therapies that we know are established for older adults, and there are others that are not listed here. So, you know, problem-solving treatment is part of PEARLS. It's a type of psychotherapy, cognitive behavioral therapy, interpersonal therapy, insight-oriented therapy. Behavioral activation is the other piece of PEARLS. And then antidepressant use, which can be sort of a sticky subject for some clients, but can be really beneficial, especially if they're sort of plateauing on their progress with PEARLS. They may need a change in dose. They may need to start an antidepressant. They may need to talk to their PCP about other medications that they're on that may be contributing to their symptoms. You and coaches may hear about physical activity as a treatment for depression, and there is good evidence for that, but it's usually not a standalone, especially for the older adult population, more of a complement or supplement to other treatments. So just be aware of that. Oops, I went backwards. Okay, before we go on to the next section, I'm just going to pause and ask if anybody has questions about anything that's come up. I'm trying to see everybody's face, but no questions. Okay. All right, so for the recruitment, screening, and the eligibility, this is where you would refer to, in an in-person training, to the process flow chart, which is a white handout, and the PHQ-9, which is a blue handout. The colors are arbitrary. We color-coded them a million years ago, and these are the colors that our office had on hand. So we've just always had them that way. We do recommend, if you are doing handouts as part of your in-person training, color coding is super helpful to just be like, okay, pull out the blue form, and then we're going to go through that. It just makes it easier, more efficient for you guys, but you can make them whatever color you want. The toolkit, the recruitment and screening section is awesome, and then the appendices have all the forms. So Appendix A is going to have the forms that you need for this section, and the content that we're covering here, if you're doing like a PEARLS practice session, this is all information that would be covered in Module 2 for the online training. Okay, so on the process flow chart, we're covering these first two sections of the flow chart, so the recruitment and the screening. Screening can be done by phone or in person or a combination, or Zoom if you want in this day and age. And letting folks know that the intake and session one sometimes go together, but actually what we're hearing more now is if folks are doing it remotely, they tend to break up that intake and session one into two separate ones. They're doing it on Zoom. It's a lot more taxing to, or over the phone, it's more taxing. So those tend to get broken up into two sessions. So it's up to them. We don't care. It's whatever their funder's willing to pay for and not burdening the participant with, you know, form fatigue or whatever the proper term is. Okay, recruitment. You all have been doing this a while. You know that recruitment can be a challenge, or even if it's not a challenge, especially in the beginning, it does not take zero time. You know, effort is involved in getting folks into the program. Hopefully over time, the referrals will start to create a snowball effect, and you know, there will be a wait list, so they have folks to come to referrals more easily. But it's something that does need to be covered in training. So you can go through all the different ways of doing outreach, you know, anything from printed materials like flyers, brochures, newsletters, postcards. We have some folks who have done radio interviews, or in Washington and California, I think tapping into local Spanish-speaking radio stations to, you know, do an interview or talk about it, or doing video blogs and testimonials. Referrals can come from internal from the organization, from local providers, but you may need to do presentations either out in the community or in assisted living facilities. But you may also need to do some presentations for providers to help them really understand what it is that Pearls is and isn't. And so really highlighting that for the coaches is important so that they are not wasting their time sifting through referrals from providers who don't understand what Pearls is. I mean, this is where your expertise and experience is really, really rich and helpful in trainings. And it doesn't matter if you're doing an in-person or an online training, like any anecdote that you have from your experience all it's gonna do is help make life easier for the next generation of Pearls coaches. So we do have some templates and examples. If you have templates and examples, you can share them with them, and just always encourage the coaches that if they make new translations or new materials, encourage them to share them back with us so that we can share them with the entire Pearls community. We're big on that. We're as open source as we can be, basically. It benefits everybody. So we'll get more into this in the implementation later on in webinar 6 and 7. So you will want to teach folks how to engage new participants. So introducing themselves over the phone. You know, you can remind them to name drop if there's a case manager or a referring provider of whatever source. Remind them that there's a lot of really negative scams and things out there, and there's a lot of wariness, especially among older adults, about getting phone calls from strangers, and that's totally fair. Like they should be wary. But if you have a referral from somebody that they know, an organization or a name, remind them to use that just to get over that first hurdle with the participant. And then engaging them in a little bit of conversation, offering to answer questions. During the in-person training, you know, if there's time, it's always great to have a little breakout session where folks can practice introducing Pearls to a partner, working on that 30-second elevator speech. And it will remind them that it takes time to hone their spiel, basically. But they'll want to practice that so that if they're trying to reach out to a participant, get them on the phone, make that connection, and then tell them very quickly a little bit about why they're calling, and then being willing to answer questions. They don't want to say too much about pearls because you don't want to build any expectations, but we just want to gauge their interest, try to tempt them into wanting to learn more. And then, if they get their interest peaked, moving into screening. And so you would start with the PHQ-9, possibly the PHQ-2, although some referring providers may have already done the PHQ-2. And so, you can, if they have that information, they can say, okay, I have a couple more questions. So-and-so may have asked you these 2 questions, but I have a couple more for you, just gauge. Remind them that if they are not qualifying for depression with the PHQ-9, but the referral indicates, or what they're picking up on the phone indicates they are still having clinically significant symptoms, that's when the screen for persistent depressive disorder comes in, because that'll almost always catch the folks and have them qualify for pearls, even if they aren't answering a 2 or 3 on those first 2 questions with PHQ-9. So once it's determined whether or not they have depression or persistent depressive disorder, then they need to do the exclusionary conditions, which we'll get into in a little bit more, and then doing the brief memory and cognitive. So first, they need to determine if the client has depression. So it needs to be clinically significant, which means minor depression, major depression, or clinically significant depression symptoms, which would be the persistent depressive disorder. Talked about that. Our PHQ-9, this is where you can highlight for them, the shaded sections where those are, they need to have a score of a 2 or a 3 in the first 2. Okay, and at least one of them needs to be a hallmark or cardinal symptom for minor depression and major depression. The number of additional symptoms, or total symptoms, I guess, is going to tell them whether or not they have minor or major. Clinically significant depressive symptoms would be a PHQ-9 score of greater than or equal to 10 for major, and greater than or equal to 6 for PHQ-9. Did I see? Did I raise their hand? Okay, got something flash. And then the persistent depressive disorder screen comes if the PHQ-9 has not revealed depression. This comes up as confusion a lot during the in-person training. Well, actually both trainings, especially for folks who haven't done a lot with the PHQ-9, or maybe they are very familiar with the PHQ-9, but they've never screened for persistent depressive disorder. They don't need to do both unless the PHQ-9 indicates that they do not have minor or major depression. Does that make sense? Yeah, so reminding them that, but we get that question quite a bit. We do have some tips for administering the PHQ-9 that are helpful for you to highlight to coaches. So that we have a form that has the different response choice cards in large print. That can be really helpful. Having them sit next to them, having the person have a copy of the choice cards. Like I said before, trying to be neutral. Read the lead into the question fully each time. So over the last 2 weeks, have you been bothered by blah, 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 blah. You can remind them that, especially in those early days of the program where you're seeing them about once a week, it's okay to skip the in the last 2 weeks part and say, since the last time we met, or in the last week. It's let them know that it's okay to adjust the wording there. But in later sessions, when it's been a month since you've seen them, they are only asking about those last 2 weeks. Okay. Encourage them. Yeah, okay, so this is where practicing the PHQ-9 is really helpful. And if you join us as a trainer on our practice sessions, and you get to act as the participant, and all of the other coach trainees get to practice being the coach, you get to have a lot of fun with this. I mean, I do. I go into like full Broadway mode and, you know, get really ambiguous with my answers. So they say, you know, over the last week, blah, 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 blah. And I'll be like, well, I don't know. And they're like, okay. So you can always remind them that, you know, they should probe with, you know, would you say it's more of, you know, would you say more than half the days or nearly every day? You know, reminding them what a 2 or a 3 means. And then also it can be helpful to remind them to break down into number of days. For some people, that's a lot easier. So it's been 2 weeks, you know, some of the days might be like 4 to 5 days. More than half the days might be 7 to 10 days, and nearly every day might be 11 to 14 days. You know, helping them break it up in different ways can help the client think about it in a different way that makes more sense or resonate with them a little bit more. Okay. I got a little caught up in my own mouth. Okay. Remind folks for some of those dichotic questions or multifaceted questions, reminding the coach it's okay to take notes on the PHQ-9, or in their own notes, they can underline the symptoms that they are having, because some of those questions, especially like 3 and 5, asking about their sleep or their appetite, what symptoms are they having this week? Because those may change over time. And so even if the score is not changing, if the symptom is changing, that's good information for both the coach and the clinical supervisor. So remind them to do that. And for question 6, so it's also, PHQ-9 does have these sort of complicated questions. So asking if they're feeling bad about themselves, or that they're a failure, or that they've let themselves or their family down, like that's a lot. So remind them that, you know, they can break up the question into different parts if that's helpful, or asking the client which of the descriptions resonates most with them. Question 7 tip is trouble concentrating. That doesn't necessarily mean memory. It's more asking, like, are they having trouble focusing on activities, paying attention, like following through reading a whole newspaper article, or are they staying focused during an entire TV show, or are they sort of losing the plot, literally or figuratively? So that's a distinction that needs to be made for the coaches, because clients may push back thinking you're getting at their memory issue. Question 8, moving or speaking so slowly that someone else could notice, or being more restless, fidgety than usual. So emphasizing that it's like, would other people notice? They may be moving slowly because they have joint pain or other chronic pain. Has it changed in the last 2 weeks? There's also a visual aid. This is from our friends over at the Ames Center here at University of Washington. Just a visual representation of what some of those buckets may mean. You know, not at all, several days, more than half the days, and nearly every day. All right, here is our persistent depressive disorder screen. Basically, they may be eligible for PEARLS if they answer yes to either of these questions. So it's a great way to capture people who are having these symptoms, just not qualifying technically for depression. If they do answer no to both of them, then let them know that pearls may not be a good fit for them, and that's okay too. So the next part is screening for exclusionary conditions. Before I jump into that, any questions about the depression screening? I know you guys are all old hat with this. Easy peasy lemon squeezy, but okay. So there's generally a lot of questions around screening for exclusionary conditions. You know, conditions that exclude a client from pearls, generally speaking, psychosis, schizophrenia, bipolar disorder, substance use disorder, and cognitive impairment. But they may still be eligible if their condition is not currently active or functionally impairing. If it is well managed, under control, and they are being treated and they are compliant with their treatment. Really what it's coming down to is, are they going to be able to follow the steps and do the homework between sessions? Are they going to be able to make progress from one session to another over the course of the program? And if you're not sure, take it to the clinical supervisor. And if they're not sure, now might not be the right time. That doesn't mean that this person may not ever qualify, or that pearls may never be a good fit for them, but right now it might not be the best choice. They may need to seek other treatment first before pearls is going to be beneficial for them. Okay, so the screening tool is going to determine whether they're being functionally impaired by the presence of any of these factors. Then the brief 6-item memory cognition screen is a shorter version of the mini mental, which many caseworkers may be familiar with, but other folks coming to training may not have a ton of experience with it. So there are instructions on the form that they can follow. And the focus really is to determine whether or not they're being functionally impaired by any of these conditions. You know, Alzheimer's disease, if they have that diagnosis, chances are very low that they are going to be able to follow through with the program. They have already gotten a severe diagnosis, and even if they are currently stable, the PEARLS program lasts 5 to 6 months. A lot can change for a person with Alzheimer's disease. If they've been diagnosed with dementia, that's a big spectrum, and it's really going to depend on how they do with the mini mental and talking with your clinical supervisor about making a decision about where they are now and how well they're going to be able to follow through the different pieces of the program. It may or may not be a good fit at this time. Okay, so the screening for exclusionary conditions. So like I said, traditionally, they were an automatic screen out if they had a diagnosis and taking prescription, but over time we found that actually some people can have success. So work with the clinical supervisor. The participant needs to be able to keep their appointments, conduct the problem-solving treatment steps, and work on their homework and action plan. So highlighting that for folks, because you may have folks coming to training who are from an organization that is treating folks with, you know, some more severe diseases, and so they may give you some pushback. But PEARLS isn't for everybody, so, and that's okay. But if they can do those 3 things at the bottom, then they may have success. So this is a sort of a newer form that we've added in the last few years. The memory cognition screen, if they have a score greater than or equal to 3, then they are eligible for PEARLS. If they score less than 3, then that means that they have enough of a cognitive impairment that PEARLS is not going to be a good fit for them. So this is like part of the mini mental. What year is it? What month is it? What day of the week? What are 3 objects that I asked you to remember? The order doesn't matter, but they get 1 point for each word that they do remember. Apple, table, penny. They sound a little arbitrary, but they are. There is evidence that those words in particular are important, or are important for determining the recall. Then you just add it up, how many points they get. All right, so if they are eligible for pearls, then the coaches will describe the program to see if they're interested. And then if they are interested, review appropriate forms and move on with enrollment. They are not eligible. This needs to be stressed a lot during the training. Let them know that pearls is not a good fit for them based on the information gathered. We never frame it as they are not a good fit for pearls. They have enough going on in their lives that is tough. They don't need to feel like there's another thing that they're not good enough for or that they don't qualify for. So really stressing with the coaches that pearls just isn't going to be what they need right now, and then move on to discuss other options. Okay, before I move on to enrollment, any questions? Do you folks want to take a 5-minute break or power through? Is that a yes for break? Okay. Being movement. Jennifer, yeah.
5-minute restroom break would be awesome if that's okay.
Totally. Okay. I will see you back in at 11:58 my time. So add on the number of hours based on your time zone.
Okay. Thank you so much.
Yeah. Yep. Okie dokie. That was a fast 5 minutes. Of course, at the end of that, my mother. Okay, not important. I'm going to resume the recording and we'll jump into enrollment. All right, so I spent the bulk of our time on impression criteria and screening because those I feel are really important to stress during any of the trainings that you'll be doing. The enrollment paperwork or enrollment process and paperwork is pretty straightforward. So we're gonna sort of hustle through that a little bit. So for an in-person training, the handouts, you would refer to the process flow chart, the PH29, and the checklist of PEARLS forms, which is a really useful tool for new PEARLS coaches to make sure that they're doing all the things that they need to do for the different parts of PEARLS. The recruitment and screening section and the PEARLS Session 1 subsection of the PEARLS Sessions section in the toolkit are where you and coaches will go to for help on this material. And then, of course, forms are in Appendix A and Appendix B. And then this information is covered sort of in both Module 2 and Module 3 of the online coach training. Okay, so this part of the process is really, some of this could be part of screening and intake, but it also may be part of Session 1, which I mentioned earlier. It sort of depends on how they're doing their recruitment, screening, enrollment, and sessions in person versus over the phone or remotely through Zoom or whatever else. Are they doing it in a group format? You know, different things. So there's flexibility here is the point. Okay, so enrollment forms in Appendix A, we have the consent and release form and the participant information form, which is demographics. These are optional forms. It's okay for coaches to use the forms that they already have, whether that's for consent or demographics. We have created these as tools for organizations who don't already have forms like this in place, but a lot of times the coaches are coming from organizations where they're at least collecting some of the information, and so they can supplement what they're doing. It doesn't have to be these forms. For Appendix B, we have the baseline questionnaire and then some templates for letters to primary care provider, mental health provider, if applicable, case manager, if applicable. Baseline questionnaire is not quite optional. It is recommended that they use the baseline questionnaire that we provide. Now, you don't have to duplicate it if there are parts of it that are already being collected for other programs that the participant has participated in. But these are the measures that we collect at the beginning and end of the program, and these are the ones that we recommend. Organizations, they can tweak it, they can add to it, but this is the core of what we over time have built the evidence with, or the baseline and final questionnaires. If they don't use these forms, that's okay, but they won't be able to compare themselves against other PEARLS programs, which it's not a competition, but you know, when they're going for funding and stuff, a lot of times organizations do want to be as close to fidelity to the program as possible, and so that's where we are going to recommend using the baseline questionnaire. Does that make sense? If you're confused, coaches are going to be confused. Okay. All right, so for conducting PEARLS sessions, they need to, at Session 1, they need to introduce themselves, they need to introduce PEARLS and go through the principles of what PEARLS is, the structure of the treatment, what it is. that's laying the groundwork for the rest of the program. It's setting the expectations and the norms for how all the future sessions are going to go. They need to administer the PHQ-9. Certainly it is built into the baseline, certainly at baseline, and the final questionnaire also has it built in. We really, really, really want to push them to do the PHQ-9 at every session. So if somebody comes through your training and they really have questions on it, you can push them back to us and we will talk to them about it. But PHQ-9 is an important tool for checking the progress, but also seeing what's going on in their life at that point, especially with question 9, asking about suicidality and, you know, taking the temperature on what's going on in their lives. They are going to need to teach them all about the principles of PEARLS, so that the part of what PEARLS is, yes, the problem-solving treatment and the behavioral activation, but it's also teaching the client about depression and understanding that even if they don't like that word, the symptoms that they're experiencing are part of this larger picture, and that's what we're working on to help them feel better. They're going to generate a problem list at session 1, and then continue to revise that as time goes on. And they're going to go through the 7 steps of problem-solving treatment and the activity scheduling, the behavioral activation piece as a worksheet. So that's the flow. We're teaching the coaches, like, this is what is encased in all of these PEARLS sessions. You don't do everything at everyone, obviously, and we'll teach them that, but those are all the different components that go into what the program is. So baseline questionnaire, first session only, and really helping the coaches understand that this is establishing baseline information about their depression and how they're engaging in physical, social, and pleasant activities. There's lots of other questions in there, but that's the picture that we were trying to paint. Similarly, the final questionnaire is going to paint a similar picture, but at the end of the program, and that the changes and comparisons are both going to give the coaches and their programs data about, you know, how much has changed and what an effect they had. But it's also going to be reviewed at the last session with the client to help them see what improvements they've made or what things about their experience have changed and how their life is different. Administering the PHQ-9, reminding the clients that symptoms are a sign and indicator of their depression. And if it helps to think about it as like physical symptoms of the cold or the flu, you know, a cold doesn't necessarily have the same symptoms. You know, it is a syndrome really, where people can have different symptoms, but it's all classified under, you know, having a cold. It's a good way to lay the foundation for each session. Take the temperature, see how it's going, and then move into the worksheet, the structure of the rest of the session. It gives them, you know, the overall structure, and just like they know that they're going to start with this. Every session is going to start the same way. They're going to see how they're doing, and then they're going to check in about how things went the last time. And over time, the flow will build for the coach. Coaches will get their groove, but they will also find that the participants learn the groove themselves, and it gets smoother and smoother for them, which is the goal. We want this to be a natural process for the for the clients, because remind the coaches, they're not going to be going there forever. It's a time-limited program, and so their job is to teach the client how to do these things on their own after they are no longer seeing them. That is how they are going to maintain the momentum and keep those depression symptoms reduced. Okay, so one FAQ that comes up not infrequently is, what if the client says that their PHQ-9 symptoms are caused by something else, like other chronic conditions? So you can remind them that PHQ-9 is determining the symptoms of depression themselves, not what caused them. So it's okay if, you know, somebody has a knee injury that's been going on, it's been giving them trouble for 20 years, and it's a lot of pain, and they can't move because of that. PEARLS is not spending time trying to determine why the depression is happening. That's where therapies of different sorts, whether it's physical therapy or, you know, psychological therapy, you know, lots of different options there. All we're focused on in this program is to identify those symptoms and then work towards addressing the overwhelming problems that are maybe causing it, but maybe just exacerbating those, and finding ways to improve their mood and energy through increasing physical, social, and pleasant activities. So PEARLS isn't going to do much about the knee pain itself, probably, unless it's working through a problem, getting towards getting a diagnosis or getting treatment. But it's going to work on other stuff around it that can help them get active in a way that doesn't trigger their knee or, you know, doesn't exacerbate their pain. That distinction makes sense in how we would teach that. Okay, so some tips for administering the baseline questionnaire. It may be easier for coaches to administer verbally, and we have a printout of different response choices that they can refer to. For social activity, we're really trying to get an idea of what is usual for them. You know, they may have done 3 things in the last week, but is that typical for them? So that's what we want to encourage coaches to do, is get a sense of if what we're asking about in the past week is a typical week for them. You can also use social connectedness measures instead, and I'll get to that in the next slide. The physical activity section emphasizes that the pictures are examples. They don't all have to be running or doing things. You know, let the client talk about their physical activity, what they do, how often they do it, to help the coach get an idea of like what type, like how intensive it is and how frequent they're doing it. We recommend that they ask the last 2 questions about weightlifting or flexibility, even if they do 0 of that. It's okay, it's not a judgment. We're just trying to get a sense of what they do, what they haven't done, give them an opportunity to share about injuries that might have, and it's all contextual information for the coach to use to help them pick activities that are going to be safe and accessible to them. And if the coaches have different questions from their organization that they want to throw in, that's okay too. So you've seen this a million times. I'll show you that. Okay. So we have a couple different social connectedness measures that we have tested in research studies. One is the 3-item UCLA loneliness. We would recommend that that is asked during screening. Could also be used at the end as an outcome. And this is asking about relational connectedness, social connectedness, perceived isolation. The 10-item Duke Social Support Index is something that we have asked at each PEARL session to educate, monitor, and assess. And it's asking more about like social interaction frequency and more of a subjective or perceived support. So I know that some of you from California who are participating in this bigger initiative are doing some of the social connectedness stuff. So if others have questions about incorporating social connectedness, we can share some of that. I can upload it into the PH1 link. But this is a topic that is coming up more and more, and coaches may be quite interested in programs, may be interested in incorporating it into the measures that they're asking. Okay, so introducing pearls to a participant. Any questions? Remind coaches they don't need to introduce themselves at every session, hopefully. Hopefully folks remember them between sessions. So they don't have to do that whole spiel all the time. It's only session one. Generally, it's going to be 8 visits over 5 to 6 months with a tapering frequency. Sessions 1 to 3 are weekly. Sessions 4 and 5 are every other week. And then sessions 6, 7, and 8 are monthly. And then there are a couple of follow-up phone calls and just to check in. Those are not working sessions. You can refer to the flow chart if that is helpful while people start to get the cadence of how things go. Generally, they're going to be about 1-hour sessions. Session 1 may be longer. It's okay to divide into 2 meetings. First session might be a little bit more conversational as you start to build that rapport and get to know each other. It's going to take some practice for the coaches to help them stay on track. Sometimes clients have a lot to say and you're asking them about themselves, and not all providers do that. And so they need to rein in, use their clinical skills for big talkers. Or they might have some clams that don't want to talk at all, and it can take a little bit more effort to draw them out and start to build that rapport. And the baseline questionnaire will hopefully help get some of those conversations going. But if they are really struggling, even a couple of sessions in, that's where talking to the clinical supervisor can be really helpful. Get some ideas of how to get the conversations flowing a little bit more. So they are going to, after they get through getting to know each other a little bit, they're going to start teaching the problem-solving skills, starting with just one thing at a time, and they're going to pick one thing each week and do some tasks in between sessions, and then they're going to pick something pleasant, something social, and something physical, just to like get out of that cycle of depression. This is not a deep dive into their childhood trauma or anything else, and an extensive background history is not important to pull out of people for this. We are not doing psychotherapy. And that can be real hard for some folks with, depending on their background, and be a natural thing for them to try and get more of the background history, and that's not necessary for pearls. And hopefully that is a refreshing thing for folks, for participants, not feeling like they need to dive into all of that to have an effective treatment. Okay, so the principles of pearls, these are important. This is what we are trying to teach all of the clients coming through. Symptoms are due to depression. So the things that they are experiencing are because of depression. We're going to track those during the treatment. That's why we do the PHQ-9. Second principle is that there is a link between the depression that they are experiencing and unsolved problems. Everybody has problems. That's normal. They can create a negative mood, and that negative mood is a clue that there are problems somewhere. They may not even know what those are yet, but that's what they're going to be getting to. The depression might be caused or might be exacerbated by whatever the problems are. And as the depression gets worse, their ability to solve those nebulous problems gets worse, and it creates this vicious downward spiral. So they will be using problem-solving treatment to break up one problem at a time into bite-sized pieces so that they can take some degree of control and make it less of a problem, which will hopefully make their symptoms better and their mood better, and then they'll feel like they can take on a little bit more and a little bit more, and then they'll feel better. And so it's reversing that spiral. And then the last principle that coaches are supposed to be teaching their participants is that increasing activity also decreases depression symptoms. So when they're depressed, they stop doing things that they enjoy. Maybe physical, maybe just social things, maybe enjoyable things. So the fewer things that they're doing, doesn't matter which type, the less good they feel. And so that's that cycle. So the more they can highlight doing just something pleasurable, whether it falls into physical, social, or pleasant events, it's going to give them just a little bit of little boost of endorphins. And then that little boost might be enough to do just a little bit more. And once they do a little bit more, they feel just a little bit better and breaking out of that cycle. So that's what we're moving towards. And reminding coaches that, like, in the beginning, the problem, the whole worksheet can feel like a lot for some clients, and it's okay to focus a little bit more on that behavioral activation piece, because if they can get them to feel just a little bit better by the next session, they might feel a little bit more able to take on a bigger problem or tackle the problem again more effectively. They didn't have success the first time around. So after they've explained what PEARLS is and they've talked about what those principles are, that's when they're going to start brainstorming the list. And then this is just a place for those problems to land. This is a dynamic list. The coaches should definitely be taking a copy of it, but the list stays with the participant, and they can put it on their fridge, they can add to it, they can cross things out if things have been achieved or if they're no longer really an issue for them. So, and it's sometimes when they are coming to a session, you know, if they can't think, if the participant can't think of anything, you can refer back to the list, but they don't have to. It doesn't have to come from that list. Participant may come up with something that happened to them that morning and they want to work on it, and that's okay too. Like, it's there as a resource and a parking lot for those ideas to be listed, but they don't have to be drawn from that. And of course, it's always okay to use other words that make sense to the person they're working with. Problems may be triggering for them in some way, and that's okay. They can use other words. So the core components of PEARLS are doing the problem solving 7 steps, the behavioral activation, activity scheduling. Those are the legs of the PEARLS stool. The floor is the clinical supervision that they sit upon, but altogether that is what makes PEARLS. The worksheet just has everything in one place, and so there may be some overlap in the activities, especially between like pleasant activities or physical activities. They may be part of some of the steps in the problem-solving treatment. They can have to do with each other. They don't have to. They can be totally separate. And just there, I've found, especially in the online training practice sessions, there's sometimes confusion about like which pieces of the worksheet go with what and what is the behavioral activation again. So reminding them it's that bottom part of the worksheet, and it is important. It should not be skipped over. It seems little, but it is mighty in helping to break that cycle of depression. So, okay, that was so much talking from me. We covered a lot. I'm going to go quickly through a summary. I'll skip over to the teach back, and then I'll come back and we can do question and answer and FAQs and prep for the next seminar. Okay, so we went through the depression criteria. You got to have those hallmark or cardinal symptoms for it to be depression. Otherwise, you're going to do screening for persistent depressive disorder. If they've screened with depression or persistent depressive disorder, then you're going to move on to screening for exclusionary conditions. and do the mini mental, and see if Pearls is going to be a good fit for them. If it might be a good fit for them, you tell them a little bit more about program, see if they're interested. If they are, then they move on to enrollment. Okay, stepping ahead, and then we'll come back. Okay, so in like, we don't have 5 minutes, so like 3 minutes, does anybody want to tell me some general tips for administering the PHQ-9 that you would want to be sure to tell folks who you are teaching?
I can do it.
Great.
So I would just explain that this is a tool that we use to gauge where you're at throughout the program. And when I'm teaching new coaches coming on board, I would make sure that they are using that visual cue card. And I had an epiphany while we were talking about this because I always forget it. I have it in a separate folder, but I'm thinking I should print one of those for every client folder, just so I have one with each folder. And just make sure that you're reading the lead-in questions fully each time before going into the question. And using the visual guide, I think, does help the client too to determine which one is most appropriate for their symptoms. And also know that it's okay to take notes on the PHQ-9 because some of their lack of sleep or whatever example could be due to pain of some sort or anything else like that. So it's nice to know that and compare note to note over the course of their sessions. So that's all I got.
Great. Any other tips that people would want to remind folks of, either that we talked about today or that you've just picked up on in your own experience?
Yes, if I could add, Nicole did such a great job just talking about the whole overlay of the PHQ-9, but I just learned something really important today. It was a good reminder, is to keep how I question everything very straightforward. Caitlin, I think you mentioned if a participant answers in whichever way, just take it as is. I don't want to follow up with the why because, or to frame it a certain way, just make it very straightforward, neutral, so that I don't influence how the participant may process or answer that question, because they might want to please the coach, or they might want to, they might feel like they have to answer it in a certain way. So bottom line is that I, as a coach, would not want to influence their answer in any which way. So to keep it very straightforward, no, no even body language or tone that would like suggest one or the other way. So just to add on, piggyback on what Nicole already provided. That's all.
That's a great point, Jennifer. And actually what you said reminded me something. In addition to not wanting to influence their response, we also don't want them to go like on a total tangent over, like the PHQ-9 should be 10 minutes or less. Like that does not need to take up the entire, but sometimes it can lead into like their whole backstory. And so it helps stay neutral, helps stay on course there, right? All right. Also using the language they use. Great, Sandy. Yep, yeah, it can get pretty jargony pretty quick. So that's a great point. Okay, second teach back in 2 minutes or less. Sorry, I have a lot to say about depression. Describe the 3 Pearls principles to a new participant.
I think I can do it in less than 3 minutes, hopefully.
Great, go for it, Gloria.
Okay, so when we're sitting down with our clients from the beginning to the very end of the program, we want to really hone in on the big principles of PEARLS. The first one being that symptoms are due to depression, and everyone's symptoms are going to be different, and it's going to be something that we're always going to be checking in on using the PHQ-9 from the beginning to the very end of the program. And this is also a good tool to use because using the PHQ-9, clients will also be learning how to recognize their own symptoms. And it's something that we track throughout the course of the program. The second principle of PEARLS is that there is a link between depression and unsolved problems. So everyone experiences problems throughout their life, but when people are down and depressed, it's sometimes really easy to become overwhelmed with all of these different challenges, and challenges start to stack up and become even more overwhelming. So what we do with the PEARLS program is we introduce the problem solving technique by so people can get feel more empowered with some of those challenges that they're being faced throughout their life. And we also we're not going to solve all the problems throughout the course of the program. So we're taking it step by step, introducing these very structured steps to solve problems and breaking things down into more bite-sized pieces. And then the last big principle of PEARLS is that by increasing activity, depression symptoms also decrease. So we want people to be as active as possible by including physical, social, and pleasant activities, and that's called behavioral activation. So the more active people are in activities like that, the better they feel. Could add on more, but I know there's a time constraint.
We always can. No, you did great. That was very concise. Loved it. Anything, any feedback from anybody or anything you'd like to add? Anybody else?
You really sound like you know what you're talking about.
Yeah, I was thinking the same thing. It's like, man, Gloria's practiced this.
Yeah, I've done a few presentations.
Yeah, and it shows, and that's great. And that's why we want coaches who have some experience get that experience before becoming trainers, because that is reflected in like what you just demonstrated, and also, you know, the experiences that you can bring to the table are, like I said before, it's just making it that much easier for the next generation of PEARLS coaches. We've all benefited from those who came before us. So passing that forward. Okay, wonderful. So next week, webinar 3 will be led by Kelly Ann, and she'll be going more in depth into the different PEARLS program components and how to teach those. So homework for next week is take the quiz for what we covered today. If you have not already completed the quiz from section 1, go back and do that, please. If you're having trouble accessing it or navigating it, let me know. I'm happy to help with that. I got a little creative with the quiz for week 2. So if you hate it, let me know. Well, actually, if you hate it, let Kelly Ann know, and she'll break it to me nicely. But there are new features in how we could do the quiz questions, and I spent way more time than I needed to, like playing with them, but they also might be incredibly annoying for you. So feedback is welcome, good or bad. And then just take a look through the toolkit section on background info on PST. I did skip over the FAQs, but I answered a lot of them as we went. So we have that section linked in the PHLearn link. You're welcome to go back anytime. But if you also have, I can stay on for a few extra minutes if anybody has additional questions, or if you want to talk about other FAQs or anything else that may have come up today. If you need to go, we are 2 minutes past time. Thank you for those 2 minutes, and feel free to hop off. Otherwise, I will be on here to answer questions that come up. So it was nice seeing you all, and I will see you in future webinars. I hope you have a nice Wednesday.